Carlos Pardo. I'm a member of the Transverse Myelitis Center here at Johns Hopkins Hospital. I would like to introduce Dr. Norman Beauchamp. Dr. Norman Beauchamp is one of the neuroradiologists at Johns Hopkins Hospital and has been associated with the Transverse Myelitis Center in the past 2 years. And he's going to give some information about the use of MRI in transverse myelitis. Dr. Beauchamp.
Well, good afternoon. I'm very glad to be here today. I was invited to join the group about 2 years ago. I've been very excited with the advances that the group's making. I think it's extremely important work, and I think that the neuroimaging has come to be a very important component of that. So I'd like to talk to you about that today. And my plan for the next half hour is the following. I'm going to first work on definition of terms. I think over the next 3 days, you'll hear different definitions of what transverse myelitis is. Rather than spend a half hour debating that, I'll tell you the definitions I'll use, and then you can extrapolate those things, I think, very easily to where you are with the definitions you use. The next thing we'll talk about is current imaging techniques. One is how to optimize what you're doing now, and then some of the pitfalls. The optimization gets a little bit at the question that was asked here, why was my MR normal? Well, sometimes it's because the MR doesn't show the lesion, but sometimes it's because the technique they're using isn't optimized to what has really been shown to be a better technique. So I'll talk a little bit about that. The next I'll do is I'll talk about some of the clues that are on the imaging that you can use to get more specific with your diagnosis. Although perhaps the T2 hyperintensity doesn't tell you what it is, sometimes there's some other findings that can help you know which of the transverse myelitis syndromes you might be working with. I'll briefly touch on prognostic implications, and then I'll talk about where the future of neuroimaging is going with transverse myelitis. I think it's a very exciting path that we're on. So acute transverse myelitis, my definition, is not a specific pathologic entity. It's acute in onset. It affects both sides of the spinal cord. And there's many causes, including idiopathic acute transverse myelitis, and this is largely based on Berman's paper in neurology. Now, as you can see, these are all of the conditions. Well, actually, it's just a smattering of the conditions that are associated with it. It's in your handout. I won't go through them all. Idiopathic, acute transverse myelitis, multiple sclerosis, radiation myelopathy, neoplasms, arteriovenous fistulas, and infections. Now, when we talk about idiopathic acute transverse myelitis, it's a well-recognized disorder, but it's poorly understood. We're learning more and more about it, but it's poorly understood. The context I'll refer to it in is something that's rapid in onset, bilateral motor, sensory, and autonomic dysfunction. And I guess the point I would emphasize is that there's no evidence of compression of the spinal cord. There's no compressive phenomenon occurring. And there's no other known ongoing neurologic disease. This should be distinguished from the broader categories of acute transverse myelitis I had on the preceding slide because the treatments are different depending on the subtype of ATM that you're looking at. Now, the one thing that's completely clear from radiologist perspective, neurologist perspective, is MRI is the methodology of choice to use. CT scan, bone gets in the way, it's next to the spinal cord, it makes it hard to see. Plain film myelography, it shows you the outside of the cord, but it really doesn't define what's going on in the cord, and that's where the action is with transverse myelitis. You can look at the cord and the brain in multiple different projections without putting the patient in uncomfortable positions. You get a very nice look, detection of pathologic processes that are occurring, and you can also very clearly delineate the anatomy. But a very important point is although you can pick up where there's a pathologic process going on, and on neuroimaging that's often areas of hyperintensity, it's sensitive but it's not specific. So you might see that signal abnormality, but all that refers to in MR speak is that there's just an increased water content. But that increased water content could be due to a number of different things. There could be edema in the cord. There could be demyelination. There could be remyelination occurring. Gliosis. There could be axonal loss. There might be tumor there. there could actually be a cystic cavity in the cord called a syringohydromyelia. So when you talk about MRI and increasing the specificity, you also want to look at some of the secondary findings, A, and B, you need to make sure that you optimize your imaging. You want to be able to pick up the lesions that are there, you want to be able to characterize them, and you want to also look at the other areas on the scan that might give you some clues as to what's causing that bright signal. So optimizing techniques, and this gets again to your point, what's good for the brain isn't always good for the spine. Imaging, that's particularly true. As clinicians and folks in the community, when we first started doing MR imaging, when we were trying to pick something up in the brain, we did something called spin density and T2 weighted imaging. And that spin density image was wonderful. It would show you what was abnormal fluid. If there was a pathologic process in the brain, it would show you quite well. So here's the spinal cord. And although I'm probably the only neuroradiologist in the room, all you need to know is that focal bright in the cord is bad. Okay? So I would ask you to say, do you see a transition here on this spin density image? I think you'd say the answer is no. The next thing that we did in the brain is we did something called fast spin echo imaging. It was a little bit quicker. It showed you brain lesions very nicely. And here's the spine with a fast spin echo image. And what I think we'd all agree, if this gray is the spinal cord, there's definitely an area of abnormality here in the cord. Then the cord gets normal in signal. Okay? So you see that lovely. Okay? Here's water around the cord. Then what we did in the brain is we said the problem is you can't tell normal fluid from abnormal fluid. This is normal CSF. This is abnormal. It's pathology in the cord. Let's do something called fluid attenuating. You make the fluid that's normal turn black. The fluid that's abnormal should stay bright. We do it in the brain. It works wonderful. So everybody said, well, let's just convert to that in the spine. Here's a FLAIR image. I'll just do that. And do you see where the bright white shows up? It's very difficult to pick that up. So this might be an MR that you would have done, and it would be normal. It's not normal. It's just the wrong sequence to pick up the disorder that's going on. The right sequence, in most places are using this now, is this fast spin echo T2. Okay? There's now a technique called a fast stir sequence. This is available on most scanners that are in the community. A lot of folks aren't doing it, but they should. STIR refers to short tau inversion recovery. STIR. We're simple people in radiology. We want to be able to remember it. STIR. Okay? Short tau. When you do a FLAIR, you suppress the fluid. Okay? But when you do this shorter tau, which refers to something called an inversion time, you suppress fat. Okay? And although not completely intuitive, what that does is it makes it so that lesions are very conspicuous in the spine. So here is that fast spin echo. Here's the short tau image. And you can see very nicely this area of bright signal is more conspicuous than even the fast spin echo T2. In doing a comparison side by side, Roca et al. Showed that this technique picked up 66% more lesions than T2 weighted sequences of the spine. So although lesions were there, they were more nicely picked up with the faster sequence. So what are pitfalls? Some of the pitfalls we'll see is people will come to Hopkins with a diagnosis of, we see bright signal in the cord. So I want to tell you one of the pitfalls you have to watch out for is called truncation artifact, okay, or sampling artifact. What does that mean? Essentially what you do with MRI is you try to describe the anatomy that's there by lots of sine waves, okay? You want to put together a picture by lots of curvy waves. And the more sharp the transition, the more curvy waves you need, okay? We call it phase encoding. If you don't do enough phase encoding steps, what happens when you get to an interface that's dark signal and then bright is you get this reverberation, okay? And it can put dark signal, like this dark signal, right smack dab in the middle of the spinal cord. And people will misdiagnose that as a syrinx, a cystic cavity in the cord on T1, or as abnormally bright signal on T2. It's a very easy problem to solve. All you have to do is you just increase the number of phase encoding steps, and then that straight line goes away. You just need to be aware of it because it can cause artifacts that might lead you to misdiagnose somebody on the MR. The other thing that was showed by Beauchamp et al. Is this truncation artifact can also simulate cord atrophy when the cord's not atrophic. So when you go back to your imaging institution, just make sure that they're doing enough phase encodes in that direction. You don't see that line a lot. The number to take with you is 256. The next thing that we see as a problem is pulsation artifact. One of the causes of transverse myelitis is a dural fistula. If you hold up your hand, okay, and you think about how your artery comes from your heart and then to your and then back to your veins and into your heart again, it goes through a process of slowing in the capillaries. So blood goes out and it starts slowing, and then comes back. If the artery connected too quickly to a vein, the flow would go a lot faster. There'd be no chance for the blood to get all the way out. Instead, it would take the easiest shortcut it could. It's like when you're trying to get to work in traffic. Okay? That process can actually cause ischemia to the spinal cord. And when you can diagnose that problem, you can fix somebody immediately. If they have that dural fistula, we can diagnose it and fix it. Now, what does the dural fistula look like? What it looks like on MR is areas where you don't get signal back, little black spots in the fluid around the spinal cord, okay? And that should make sense because what happens is the veins all dilate up. What can happen, though, is you get pulsation artifact. Pulsation artifact is because as your heart beats, as you're sitting there, your brain gets bigger and smaller, okay? And it causes your CSF, your spinal fluid, to move, and then you don't actually get all the signal back from your fluid. You get little dropouts, little dots like this. So what you have to be careful of is you have to be careful of that pulsation artifact and not call that a dural fistula. Because if you call that a dural fistula, then you're going to be referred to me and I'm going to do a spinal angiogram, which is going to take about an hour of your time. And if you don't need it, you don't need it. This is what a dural fistula, this is what the vessels look like. They're multiple, they're punctate, and you would see them on the T1 and the T2. This is normal pulsation artifact. You'll see them throughout the spine. They're more in the cervical and the thoracic. And the way to get rid of that is you just use something called flow compensation and cardiac gating. As I said, the brain moves with the heart pulsations. So if you just image every time the heart's in the same cycle, you'll get away from those flow artifacts. Very straightforward to do, and it prevents a misdiagnosis. The last pitfall is one of the things that portends not as good an outcome is if you have a cystic cavity in the spinal cord. One of the challenges is diagnosing when you have a cystic cavity in the spinal cord. What some people will do is they will say, I know that the T2 sequence shows me fluid. So if I see a spinal cord and I see bright in there, that's fluid, that's a syrinx. There's a cystic cavity. I just want to emphasize that the T2 shows you all of those different things that are bright. Sclerosis, remyelination, demyelination, tumor. The best way to differentiate if something is a syrinx or not is on the axial T1. As I told you, the sagittal T1, sometimes you'll be fooled by that truncation artifact. So I use the axial T1, we use that, and if the center cavity is the same signal as the fluid around the cord, that's when most folks are comfortable diagnosing a syrinx. Okay? Now we'll go over some general rules that people have come up with in looking at a number of cases of different entities within the transverse myelitis syndrome. There is a paper by Tartaglino, the references are all in your handout, where they looked at a number of patients that had idiopathic acute transverse myelitis versus multiple sclerosis related. And what they found out is in looking at the spinal cord, there's a couple general rules that you can use. Not always the case, but it increases your specificity a little bit. The lesion length, the majority of the time, it involved greater than 2 segments, 2 vertebral body segments, and here you see bright extending past 1, 2, 3, 4, 5 segments. Okay? It involved the majority of the cord in cross-section, greater than 50% in the majority of the cases, and there was an absence of intracranial lesions in the majority of the cases. That's in part due to your definition. That's idiopathic. Here's another example of the same thing. T1 weighted image. Difficult to see much. There's a little bit of low signal there. Here there's bright signal throughout the cord. Okay, more than 2 segments, and there can be enhancement as well. That's a very characteristic appearance for idiopathic transverse myelitis. What about multiple sclerosis? 2 other investigators looked at a number of patients with multiple sclerosis. And what they found, comparing that to transverse myelitis and other disorders, is that in the majority, lesions involved 2 segments or less. Again, general rule, it extended for less than 2 vertebral body segments. It tended to be peripheral in location, whereas transverse myelitis almost always has some central involvement of the center of the cord. Very often, MS lesions are peripheral, and they typically involve less than 50% of the cord on a single axial image. As was nicely mentioned by the previous speaker, assigning a diagnosis of multiple sclerosis is greatly helped by looking at the brain. When we looked at people that had lesions in the spinal cord, only 12% of the folks that eventually went on to have multiple sclerosis did not have lesions in the brain. Okay? So again, if you have a lesion in the spinal cord, 88% of the time, if you have multiple sclerosis, you'll have a lesion in the brain. Okay? That's point 1. The second point is as we all age, we all get little white matter lesions in the brain, unfortunately. By the 3rd decade, you can have 1, 4th decade, 2, etc. I did a study on like 3,660 people. You get them as you grow older. So what you want to make sure is when you call a lesion an MS lesion, because of the implications, you want to try to be fairly specific that that's what you're talking about. One rule that's nicely recognized is if you see the orientation of these white matter lesions perpendicular to the long axis of the brain or the corpus callosum. So these lesions you can see are going out. Some say they're perivenular, and there again. Now the other rule that I like to use is the corpus callosum is very well perfused. It gets blood supply very nicely from the short and the long callosals from the top of the brain, the depth of the brain. One of the main reasons you get white matter lesions in the brain is atherosclerosis. So when you see lesions like this, you want to say, can I be pretty sure it's not atherosclerosis? A good way to tell is when you look at the sagittal MR, if you see involvement of the inner third of the corpus callosum. See how these look like little mouse bites, I guess you could call them? There. What that is that's involvement of an area of the corpus callosum that has a whole lot of blood supply. It would be unlikely to be ischemic. So if on the sagittal image you see these lesions on the inner 1/3, that again supports that they're not ischemia, but rather much more likely to be an MS-type lesion, because the corpus callosum is very resistant to most types of lesions. Devic's, Neuromyelitis optica. Again, it's a bit of term definition, but that refers to when you have optic neuritis or history of optic neuritis with a spinal cord lesion. Now, some folks would say that this is the same disorder as multiple sclerosis. Now, I'm not as knowledgeable as some of the people who've dedicated their lives to the markers of Devic's disease, but there are things that are different. The IgG levels are different in Devic's versus multiple sclerosis. And they also, a recent publication talked about matrix metalloproteins are different. So they're different entities. And it also makes sense when you look at their spinal cord manifestation. The extent of involvement resembles much more idiopathic acute transverse myelitis than MS. It tends to be longer in extent. It's oftentimes necrotic, so you can have the T1 dark signal about 50% of the time. On the T1, you'll see that dark area. And again, it covers multiple segments, and there can be mass effect. Okay? So if you're trying to differentiate this from idiopathic, you would look for the history of optic neuritis. Acute disseminated, there should be a D, encephalomyelitis, is a disorder that comes on. It's a immune-mediated typically, and it tends to be multifocal. So if you saw an image like this, you might suggest that this could be idiopathic acute transverse myelitis. Things that would support that is oftentimes there are long segmental lesions. This is a T1, but there actually was extensive involvement. But the way that I think you can nicely sort it out is again by looking at the brain, somewhat similar to multiple sclerosis. In multiple sclerosis, you often won't see multiple lesions all enhancing at the same time. With acute disseminated encephalomyelitis, many of the lesions will enhance and some of the lesions won't. On follow-up examination, the lesions will continue to enhance. So when you look at trying to differentiate acute disseminated encephalomyelitis from MS, serial MRs help you. Because what you'll see with acute disseminated encephalomyelitis is some of the lesions will start to clear, other ones will start to enhance, and that goes beyond, when the symptoms are still getting better, you can still have new lesions showing up and enhancing. So there's a disconnect between the MR findings and the symptoms. A couple more, and then we'll move on to the next. Radiation myelopathy. This would be one where I would tell you the history's on the film. I can look at this and I can tell you what this is, although it's kind of a nonspecific lesion. The reason is, so here you see bright in the cord. The clue to this is that when you give someone radiation therapy for like nasopharyngeal cancer, breast cancer, something like that, what happens is it can injure the spinal cord. But in order for the radiation to get to the spinal cord, it goes through the vertebral bodies. Okay? See how these vertebral bodies are bright white? You get fatty infiltration of your marrow when you have radiation therapy. And sometimes your patients don't give you all the history that you would like. And so this would be a way where you would say, no, you don't have transverse myelitis. You likely have radiation-induced injury. Dural fistula, we talked about that. The reason that I think this is very important is because it's very easily treatable. If we diagnose a dural fistula that you have, we can clip it and your symptoms will often stop progressing and sometimes they'll actually get a little bit better. What is a dural fistula? Again, it's what I talked about. It's where you have too soon a connection between a normal artery. Here's a picture of your spine. Your arteries come back and they connect to your spine. Normally what happens with your arteries is they come out and they taper like this one's doing. Okay? In someone with a dural fistula, what happens is they connect too soon and then you see these dilated venous structures. And that causes ischemia to the cord. In the past, Dr. Kerr and his colleagues would be very reluctant to refer you for a spinal angiogram to neuroradiology because it was a major deal. The patients would get general anesthesia. It would take 4 hours. We might have to bring you back another time. It was a big thing. And so you'd have to risk-benefit balance and say, well, it's a lot to put a patient through. What we found now is we've optimized our techniques. We can generally get through these in about an hour. We can keep our contrast under 200 cc's, and we don't use general anesthesia. So it's a much more straightforward thing that, if your index of suspicion is moderate, it's reasonable for us to look. And I think the nice thing is we're already starting to see techniques with MR and CT where they're getting closer and closer to being able to diagnose these without even subjecting you to any type of angiogram. I think that'll be a little bit further down the road, but not too distant. The final things I want to talk about is spinal cord tumors. One of the issues that folks try to separate is, do we need to biopsy this lesion? Someone has a lesion in the spinal cord. I'm concerned it's a tumor. There's a couple nice rules that you can use to separate tumor from acute transverse myelitis and the other entities. One is, for MS, for example, it tends again to be short segments, less than 2. There was a large series done looking at spinal cord tumors and when they presented, and there was one case in about 270 that was less than 2 segments. So if you have something less than 2 segments involving less than 2 vertebral body segments involving the cord, very unlikely to be a tumor. The other thing is often with acute transverse myelitis, you'll see relatively rapid progression in the first couple of weeks. You won't see that with a tumor. So rather than rushing to biopsy, you can often wait a couple weeks and see what the lesion does. There's no great rush. Other things that you frequently see, benign and malignant cysts are associated. Here's a cyst associated with this tumor. And the enhancement, the edema, which is this bright signal, often goes beyond where you see the enhancement. This is another example. This is an astrocytoma. Again, there's a cyst involved. The edema goes a long ways. It's a very dilated cord, and you can even see some scalloping on the back of the vertebral bodies. Prognostication. I was unable to find a lot of wonderful data as it related to spine imaging and prognostication. I looked, and maybe some of my colleagues can speak up after I finish, but essentially it's a lot like what you would think. If your scan was normal and there wasn't a lesion, and in some series of acute transverse myelitis, up to 50% don't have a lesion, but they have the diagnosis of acute transverse myelitis, those patients tended to do better than patients who had clearly defined lesions in the spinal cord, such as this patient. Patients that had the focal area of really dark signal, syringohydromyelia, again, those patients tended to do worse. And obviously, if you've gone on to have atrophy in your cord, as a general rule, that's, a bad prognostic sign. Future techniques, and this is what I think is really quite exciting. As we sit in this room, okay, our water molecules are moving about, okay? They move maybe 10 microns every 40 milliseconds. If I'm boring you to death, yours might be going about 30, okay? And what we've been able to do in the brain is we can actually measure changes in how much those water molecules move. So if they're moving 40 microns if they're moving 8 microns every 40 milliseconds and then they slow down to 3, we can pick that up. And that's allowed us to diagnose stroke in the brain minutes after it occurs. Now, what would be wonderful is if you could step down to the spinal cord and use that same technology. The other thing that this diffusion allows you to do is it allows you to look at the axon pathways and actually do fiber maps where you can map the fibers going up and down the spinal cord and in the brain. Certainly when you're looking at disease processes that disrupt fiber tracts, being able to image them would be very exciting. We're doing it in the brain, and a recent paper by Rees et al. Showed that they were able to do it in the spinal cord pretty well. We have more work to do, but in the brain it's exquisite, and I think the spine, we have a shot. Here's an example. This is a diffusion-weighted image of the spine. These letters just refer to the direction, okay? And what you may appreciate, or at least observe, is that the brightness here is different than the brightness here, okay? The reason is because what I'm actually measuring is how easily water molecules can move, okay? So if you got up and decided to leave right now, if you tried to come straight and go over the tables, it would be fairly difficult, and it would be hard. But if you said, I'm just shooting right down the row, I'm out of here, it would be easy. And what these maps are their intensity brightness is based on how easy it is to travel, okay? So it should make sense here. The axons are traveling up and down, and if I image in that direction, it should be brighter, and that's what I can measure. So then if you had a pathologic process that somehow disrupted that pathway, such as acute transverse myelitis, you'd start to lose that bright signal. And that's what we're on the verge of being able to use in the spinal cord. Here's an example of a case where they did that. This is somebody who actually has a compressive process. Here's a T2 weighted sequence, and you can see this is bright fluid. Now, what you don't know is this bright because there's too much edema, or perhaps what's going on is water molecules there's ischemia there. Without going on too excessively, what I can tell you is that in doing these imaging sequences, we actually can look at and determine that the water molecules aren't moving as fast in this location. And there's a somewhat limited group of processes that do that, such as ischemia, not enough blood flow, compression, and that's what's occurring here. Why would that be helpful? Well, one, I think we'll be able to perhaps begin to differentiate subtypes of transverse myelitis, tumor, demyelination, ischemia. I think it'll help with prognosis, perhaps. In the brain, when we detect ischemia, we can tell when we use diffusion if it's going to get better or not. And lastly, therapeutic monitoring. If you can see those fiber tracks maybe start to reorient as you treat a patient, that also might help guide you. Again, a little bit of conjecture, but I think perhaps. The little red thing is going off here, which is a bad sign. So I have 3 more slides I'll tell you about. The first is just flow imaging. We can image how the water moves around your spinal cord. And what this shows you here is that the water is getting held up right here. See how this is brighter, then it drops off, and then it doesn't flow back upright? There was a little adhesion in the CSF that was causing this injury to the spinal cord. They lysed this adhesion, and it helped the patient. The ability to look at flow around the spinal cord helps you now identify lesions that you might not have seen. MR spectroscopy, it's been wonderful in the brain. It shows you places of abnormality where you don't have bright signal. Is it feasible in the spine? Well, the first paper came out in neuroradiology by this investigator. She did 10 patients, and you actually could measure NAA. The problem still is that the blocks are pretty big. They're about the size of the cord. So diffusion, I think we're there. Flow imaging, we're there. Spectroscopy in the spinal cord, we still have some work to do. Last is something called magnetization transfer. That's just another technique. And what that has shown is this correlates very nicely with function, well, more so than T2 bright lesions. And you can actually measure how intact the molecules in the brain are, and that is a very nice way to measure things such as Wallerian degeneration, axonal injury, multiple sclerosis. For the sake of time, I'll just say that we can now do this in the spine very nicely, and it's another way to pick up lesions that go beyond just what's bright on a T2-weighted sequence. In summary, imaging plays an important role in what we do. I think optimizing techniques is important. Beware of those dangerous artifacts I talked about. The rules I gave you were general rules. The clinical history still dominates, but these are things that might help. And I think these new techniques hold great promise in terms of diagnostic specificity, differentiating mechanisms, and perhaps therapeutic monitoring. Thank you.